Well, hello everyone, and welcome to our case conference webinar series via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Phipps. I am a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. And just as a reminder, this event is one of many in a monthly series of webinars that kind of alternates between case conferences and educational series, the journal clubs and stuff. And so be on the lookout of what some of the next ones may be. But today's 30 to 45-minute case conference, representing the proactive psychiatry SIG of ACLP, will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end in a Q&A session. So if you have any questions, please put them into the Q&A option of Zoom. Feel free to use the chat for comments if you'd like, but we will be only answering questions within the Q&A option. Our trainee presenter today is Dr. Elizabeth Dietrich. She is a fellow in consultation liaison psychiatry at Brigham and Women's Hospital. And our faculty discussant today is Dr. Melissa Bowie, who is an associate professor of psychiatry at Virginia Commonwealth University Health System. And without further ado, I'm going to hand it over to Dr. Dietrich for her presentation.
Thanks so much, Dr. Phipps. So our case conference is entitled Take My Breath Away, Exploring the Benefits of Embedded Psychiatric Consultation for a Patient with Mania and Respiratory Failure After Parenteral Olanzapine and Lorazepam. In this case, we have a 29-year-old female with a history of bipolar 1 disorder with psychotic features, scoliosis, chronic back pain, class 3 obesity, obstructive sleep apnea, and concerns for obesity hypoventilation syndrome. She initially presented to the emergency department with disorganized behaviors, pressured speech, and agitation. While there, she received a total of 10 milligrams intramuscular olanzapine, 5 milligrams intravenous olanzapine, and 1 milligram of intramuscular lorazepam for agitation. Unfortunately, she required intubation and mechanical ventilation due to respiratory depression, and she was admitted to the medical intensive care unit. For several weeks before arrival, the patient was more anxious, overwhelmed, and tearful. She also experienced auditory hallucinations of the earth speaking to her. Prior to arriving to the hospital, she refused to allow her mother to enter the home, as her mother reportedly had bad vibes and bad energy. She denied thoughts of self-harm or attempts to harm herself. Her mother described recent physical aggression towards others as she forcefully removed her mother's glasses. The previous month, she was a passenger in a motor vehicle accident and sustained shoulder and knee injuries. Her mother also identified the recent death of her biological father as a significant source of stress. Psychiatry was consulted proactively in the medical intensive care unit for management of altered mental status and recent concerns for acute manic episode. We were unable to determine the patient's own chief complaint as she was intubated and sedated. The patient was diagnosed with bipolar disorder at 16. She last experienced manic symptoms in 2020 during the COVID pandemic. She had a history of decreased need for sleep during spring and summer months, with more depressive episodes during fall and winter months. Current psychotropic medications included lithium, perfenazine, as-needed clonazepam for anxiety, and gabapentin for chronic pain. This graph shows her outpatient lithium levels, which ranged from approximately 0.2 to 0.5 in the 2 years prior to admission. As you can see, there was a sharp decrease in her lithium level in the months prior to presenting to the hospital. She was psychiatrically hospitalized at 16 with one previous suicide attempt via intentional overdose around that time. Prior to the current presentation, she was consistently engaging in psychotherapy. However, her session length had recently decreased from 50 minutes to 30 minutes. In terms of substance use, she was using cannabis for chronic pain, and she also had a history of occasional alcohol use, and she made statements to her mother about consuming hallucinogenic mushrooms. For her family history, her biological mother had schizophrenia, and her biological father had bipolar disorder. She has a past medical history of scoliosis with prior thoracic and lumbar spinal fusion in 2009, chronic back pain, class 3 obesity, obstructive sleep apnea, and concerns for obesity hypoventilation syndrome. She has no known drug allergies, And for her social history, this patient is currently single with no children. She is unemployed. She never completed high school, but did complete her GED. Additionally, this patient was adopted as an infant and raised by her adoptive mother. Transitioning to our mental status exam, this is a 29-year-old female with obesity who was dressed in hospital attire with endotracheal tube and soft restraints of bilateral wrists in place, laying in bed. She was sedated, non-interactive, and unable to follow one-step commands in bilateral extremities or when asked to open her eyes. She had intermittent spontaneous movement of her left upper extremity in response to examination of her left lower extremity. The remaining components of the mental status exam could not be assessed due to her level of sedation, as she had a RASS of -4. Her initial presentation in the emergency department was most concerning for mania with psychotic features, with precipitants including decline in medication adherence and recent substance use. Additionally, her presentation in the ICU is consistent with mixed delirium, with drivers of delirium including respiratory failure requiring sedative agents, the use of physical restraints and urinary catheter, and withdrawal from cannabis. As the psychiatry team embedded in the ICU, our initial recommendations included transitioning from lithium extended release 900 milligrams daily to lithium immediate release 300 milligrams 3 times daily via orogastric tube. We recommended increasing perfenazine to 8 milligrams nightly. She was continued on her home dose of gabapentin 300 milligrams 3 times daily, and we recommended to defer restarting her home dose of clonazepam with plan to consider starting reduced dose of clonazepam 0.5 milligrams daily once extubated. Additionally, she was started on PRN IV haloperidol 5 milligrams every 6 hours as needed for agitation with safety concerns with dexmedetomidine drip for sedation. On hospital day 2, this patient self-extubated and was placed on a non-rebreather max. Afterwards, she became combative, attempting to remove lines, and she required maximum dose of dexmedetomidine drip as well as PRN IV haloperidol. Unfortunately, she was unable to tolerate BiPAP, and she was reintubated after oxygen desaturations due to concerns for aspiration pneumonia. Lithium was increased to 1,200 milligrams daily, and at this time, the patient was intubated and sedated on propofol and fentanyl. On hospital day 4, lithium was increased to 1,500 milligrams daily. Throughout the hospitalization, this patient's mother was frequently present at bedside. The CL team engaged with the patient's family, providing psychoeducation and support. On hospital day 6, the plan was to wean off propofol and restart patient's home dose of clonazepam 0.5 milligrams twice daily to avoid benzodiazepine withdrawal. On hospital day 8, the patient remained intubated with intermittent wrist restraints. At this point, she was able to follow one-step commands and answer some yes/no questions via head nodding and shaking. On hospital days 9 through 11, she was gradually weaned off propofol and hydromorphone drips. During this time, she received 5 milligrams to 15 milligrams of PRN IV haloperidol per day. We have 2 guiding questions for discussion. First, how does proactive psychiatric consultation achieve the Institute for Healthcare Improvement's quintuple aim? What aspects of critical care make the ICU a particularly high-yield environment for proactive psychiatric consultation? Second, how might proactive psychiatric consultation offer unique opportunities for supporting the family members of critically ill patients and assisting the team with navigating family dynamics during ICU stay? Now we will hear from our expert discussant, Dr. Melissa Bowie.
Thank you so much, Dr. Dietrich, for an excellent case presentation and the opportunity to talk about this subject in greater detail. To answer the first question, we want to think about proactive psychiatric consultation as a framework and how this can be reflected by other high-yield frameworks, which we recognize as identifying value and models of care that achieve the best of what we can do. So when we think about proactive consultation, we want to think about that as a framework of having a systemic screening process for active mental health concerns. We think about proactive interventions that are tailored to the patient. We think about team-based care delivery, and we want to think about care integration with the primary team or service. So the proactive model, of course, being sort of a flipped script from our usual reactive approach, where we're depending on the team to identify those concerns, and they're not using a standardized population-based screening approach. Now, when we think about the Institute for Healthcare Improvement, this is a global nonprofit that seeks to improve healthcare and care delivery worldwide. And this institution uses implementation science and the PDSA cycle in quality improvement. You might have heard of the model for improvement sort of being another framework within some of those, within which some of those practices can exist in a structured way. So this quintuple aim is another one of those. It started as the triple aim and then grew to 4, and now reflects 5 different achievements that are sought after by these high yield, high value care practices. Proactive psychiatric consultation really embodies this quintuple aim. And what this table shows us is the pieces of the quintuple aim, how they apply to this case, and how the ICU really does reflect a very high yield environment for that model of care. First, we think about improving population health. We achieve this through that population screening, where we're caring for a whole population of patients as opposed to the one-off patient. And allowing this, using this approach allows us to identify those really high yield targets of intervention, whether it's a pre-existing psychiatric illness or polypharmacy, perhaps a substance use disorder or a neuropsychiatric target such as delirium. So the ICU has quite a high degree of psychopathology where a psychiatrist, particularly early on, can really benefit outcomes. Next, we think about enhancing the care experience. This is often sort of thought of as patient satisfaction. In this case, by getting involved early, the psychiatrist could provide nuanced and tailored recommendations for the patient's home psychiatric medicines and also PRN breakthrough medications to minimize adverse effects. Similarly, in the ICU more broadly, this early intervention facilitates patient care, communication, comfort, not just with the patient, but with their family member as sort of an extension of them. The proactive model has also been shown to reduce costs. Some really wonderful work with by Dr. Brian Bronson and many others have shown that early intervention models are sort of one of our smartest strategies at reducing healthcare costs. Early psychiatric intervention can reduce unnecessary delays in progression of care. And this is relevant, again, to the ICU because of its extremely high cost of care. In 2010 data, of course, these are old numbers and pre-COVID, ICU care alone represented 0.72 of our gross domestic product. Addressing clinician burnout and safety, we know that when psychiatry gets involved, patients who exhibit agitation or aggressive behaviors can receive more personalized care, earlier intervention, helping with safety of the patient, but also of care teams and reducing the likelihood that they might feel burned out or moral injury. And having that sort of frequent pre-CL presence either embedded in the ICU or available as a proactive liaison or even as a dedicated liaison can show that visibility of the relationship. Finally, the most recent addition to the IHI is this advancing health equity, and using a needs-based screening approach really reduces bias against patient selection, which you could imagine the difference between identifying a patient with a pre-existing psychiatric illness because that's in your chart and you're doing that high-risk screening versus a patient who is receiving a reactive consult because of a vocal family member. So the proactive approach can truly improve equity. Moving on to the second question. How might proactive psychiatric consultation offer unique opportunities for supporting the family members of critically ill patients and assisting the team with navigating family dynamics during an ICU stay? So this question really allows us to showcase one of the recent and powerful developments within critical care medicine and by extension within critical care psychiatry and proactive models of engagement. This is something called the A to F bundle. This is championed by the Society of Critical Care Medicine as part of their ICU liberation campaign. And these 6 components facilitate liberation from the ICU. It's a little bit of a tricky acronym. Very briefly, A is assess pain. B is both SAT, SBT. These are breathing trials that a ventilated patient would require every day. C is choice of analgesia and sedation. D is delirium, assessment, prevention, and management. E is early mobility and exercise, and F is family engagement and empowerment. And that F piece is something we really want to take some time to talk about today, because it's such a critical and I believe underutilized tool in ICU liberation and patient engagement and successful patient outcomes. Studies that have looked at liberating family visitation and presence at the bedside, even presence on rounds, even, believe it or not, presence in resuscitation efforts like CPR, have demonstrated improved relationships between family members and care teams. Studies have also looked at family engagement as a means of almost serving as an extension of the team, which makes so much sense. If you have 30 minutes of occupational and physical therapy a day as a critically ill patient, perhaps your loved ones, your friends and family can learn some of those passive and active mobilization exercises and continue to deliver high yield exercises throughout the day. And studies that have looked at that piece in particular have demonstrated success there, that family really can be these champions of ICU liberation and recovery from critical illness. They can provide frequent reorientation. They can provide bedside calming and reassurance during challenging periods like ventilator liberation, where someone might have agitation that really limits their ability to have a breathing tube removed. So the liaison, the critical care psychiatrist or the psychiatric liaison, is in such a prime position to engage with families, to provide trauma-informed care and psychological first aid because they are going through crisis, to provide valuable psychoeducation, and then to empower them, sort of deputize them to serve as extensions of the team and to be helpful in these ICU liberation efforts. All right. We can go on to the next one. And with that, we can go back to Dr. Dietrich for an update about the case.
Thanks so much, Dr. Bowie. So with a brief case update, on hospital day 12, the patient was extubated and she was alert and fully oriented. She expressed feeling depressed due to her NPO status, and she identified stressors prior to admission, including the death of her biological father and unfortunately a recent sexual assault. Notably, there were no signs of mania on exam. On hospital day 14, the patient was transferred from the ICU to the medical floor, and the following day, she no longer met criteria for involuntary psychiatric hold with plan for a partial hospitalization program referral. And you can see her graph of her lithium levels throughout the hospitalization as well. But now we're going to transition back to Dr. Phipps. Thank you so much.
Excellent. Thank you very much. Great cogent presentation, as well as a really good discussion section there as well. Dr. Boo, I see your hand is up. Are you wanting to say something before we start the Q&A session, or are we good? Okay, excellent, excellent. Well, so now it's time for the Q&A session here. And as a reminder, more than happy to have things in the chat, but we're going to answer the questions that are specific to the Q&A option. We can answer questions about either the presentation, about proactive consultation, liaison psychiatry, or about the actual case itself. And one that came up particularly, this example is an example of a proactive consultation service in the ICU specifically. And many of the proactive consultation liaison services have been in some of the other units as well, outside of the ICU. So what are some of the challenges inherent to some of the ICU component of proactive care versus if someone wanted to start something in a different setting?
That's an excellent question. Thank you so much, Dr. Phipps. I think the ICU does offer so many unique opportunities for a psychiatrist with knowledge of certain classes of pharmacologic agents, with nuanced understanding of the mental status exam, even if a patient has neuropsychiatric barriers to communication or thinking in a linear, logical way, and also our focus and emphasis on psychological first aid, trauma-informed care, and understanding how to work with patients and their loved ones when they're in crisis. I think it does all facilitate early psychiatric engagement in that environment, but colleagues may have a bit of a learning curve as they encounter unfamiliar acronyms and life support devices that may just not be as familiar, that may be a little bit frightening to sort of say, gosh, I'm not sure how this patient's renal replacement therapy is going to affect my recommendation. So there's definitely a steep early learning curve as we work with our colleagues in other specialties and ICU pharmacy and others to get the lay of the land, to learn that language, to appreciate the value of these acronyms and understand the literature and how it supports the value of our interventions, and then to gradually become an accepted and welcomed member of the interdisciplinary team, because ICUs can sometimes be a little bit more of a closed environment where care providers there are used to delivering a lot of that care themselves. So they may not think to engage psychiatry. So that can sometimes take a little time to making those connections and becoming a sort of a trusted counterpart in care.
It's a good point. Learning the language and making yourself part of the team certainly is an excellent component of any CCL job, certainly.
Yeah.
Um, Got another one here about specifically asking, could you speak to the approach to proactive screening in critical care? It seems that the indication for psychiatric consultation for this patient may have been identified by teams upon admission to ICU. Are there ways that proactive approach could have informed this patient's care from the outset?
Again, Dr. Phipps, such an excellent question. I think that's part of the beauty of the proactive model, and really one of the take-home points that we wanted to emphasize as part of this webinar is that proactive screening can reflect the priorities of the psychiatric team, the patient population. It can reflect larger health system or departmental initiatives. So if there are particular areas of focus, like for example, in my own practice, I use a delirium screening where I identify patients with a positive CAM ICU or reference to altered mental status in the previous day's documentation. Other models, other more embedded models, may use broader criteria as determined and agreed upon by the psychiatric consultant and the primary team. So a pre-existing psychiatric diagnosis or certain medications, perhaps a suicide attempt prior to admission, may trigger a psychiatric consult in the ICU setting. Or you may see more of that sort of early intervention model just by having the physical presence of an embedded psychiatrist, where perhaps your emphasis isn't so much on those rigorous screening criteria so much as discussions between the psychiatric consultant and the primary team to determine which patients would benefit from that early intervention.
Gotcha. Okay, that's helpful. And so if someone wanted to start like a proactive service, for instance, obviously this requires a little bit of understanding of the inner workings of some of these units. And especially when some units may have different needs than others from a proactive perspective. How would you suggest a team start approaching this, especially when it comes to discussions of cost and discussions of benefit and tracking of benefit? How would you suggest teams go about starting one at their own institution?
Well, I think this is where we are so fortunate and privileged to have such incredible colleagues within the academy, because so much of this groundwork has been done already by Mark Oldham, by Paul Desson, by colleagues at Yale, at University of Rochester, really thinking about what tools does a psychiatrist need to build their team and integrate into certain care environments. And the proactive SIG has a number of resources that individuals can navigate to the website, download forms that really spell out very easily, how do you do a needs assessment? How do you build a financial case? Some of these financial cases in the ICU should be a little bit perhaps stronger because of those that high cost of care. We also see a growing groundswell of support through, as I mentioned previously, Dr. Brian Bronson's work looking at early proactive psychiatric consultation, the financial benefits of that, and other work in critical care realms, looking at early intervention models and the cost impact of delirium and other conditions in these care environments. So I think for individuals who are interested, there is a wealth of administrative support available through the academy. And then the other piece is getting the permission from departmental and division leadership to start participating in rounds once a week, or take some time to get to know those ICU stakeholders and start to offer them didactics, start to join their meetings, participate where you can, be a sponge and soak up their acronyms and learn, along the way, little approaches that make you invaluable as being willing to take on some of the more challenging aspects of critical illness, which are some of those neuropsychiatric challenges. And you'll find that once they let you in, they rarely let you out. They like to keep it alive, which is great.
Fair, fair. Sometimes you identify a need, and the need suddenly gets more identified.
It's
It's
still there. That's right.
fair. Is there a way to measure kind of the impact, not only from a cost perspective, but you even mentioned like well-being and burnout and how well this helps the teams even from an interpersonal level? Are there ways of measuring that and showing that to your leadership teams?
Absolutely. I think being able to do qualitative and quantitative work to measure the value of this work is invaluable. When Dr. Dietrich was at VCU and we had the chance to work together there, she conducted some really high-level qualitative studies looking at staff satisfaction in the ICU that was getting our early proactive consult model, and then comparing that with the usual care across different levels of clinicians, ICU nurses, and also physicians and APPs, and was able to demonstrate the value, the qualitative value of having early and embedded psychiatric support. Similarly, there are studies that could be done sort of ranging from quality improvement and evidence-based practice studies, sort of those things that fall under our model for improvement through IHI, versus sort of more capital R research looking at randomized control trials or other evaluations of psychopathology in the ICU environment. Joellen Wilson's done some really great work on delirium and catatonia in that environment, and really modeled some nice research studies. Just sort of simply put, as proactive models start and get off the ground, they're often small enough that they need to be piloted. So one strategy that's been successful in a number of environments is piloting a proactive model on a portion of a unit or a team, offering it to one team, but perhaps not others, so that allows for subsequent retrospective analysis of, let me look at those populations, let me look at the patients that got proactive consults, were exposed to that model, and let me look at patients that weren't, and compare outcomes that way. So there's some nice sort of research initiatives that can be baked into the model from the outset. And for anyone who's interested, I would strongly encourage you to reach out to SIG leaders, whether it's critical care psychiatry, whether it's proactive psychiatry, whether it's sort of any SIG. This is an opportunity to think about, gosh, I really like this population and I think this model would help them. And how can I start this, but also study it so that I can demonstrate my own value as I go?
And that's a really good point because a lot of times the value is a proactive, prospective piece of like getting them to their next steps, hospital length of stay, so on and so forth. Are there also ways of kind of looking backwards and saying that proactive and integrated approaches could help inform like ED care, especially since they're the ones that are really seeing them in the onset and sending them up to the ICU oftentimes or to the unit that they would be on? Are there ways that this could also influence the prequel portion in the ED? The question asker of this particular question mentioned the piece about olanzapine and lorazepam being parental use sometimes may be concerning with respiratory drive and obesity hypoventilation syndrome. So allowing for that extra bit of liaisoning even outside of where we're formally integrated. Can you speak to that question?
Absolutely. I mean, I'm a little bit of a hammer where everything's a nail, because I think proactive models really are the future of an integrated approach between that proactive early identification of these high-risk cases where psychiatry can change the course of a patient's trajectory, coupled with our reactive models of care, which are so effective in identifying those high-risk cases that perhaps are more chronic. Or I think this twofold approach is really just such a logical model. So I think in the emergency room, you could absolutely have lots of opportunities for proactive psychiatry to get involved and to improve care. For example, perhaps avoiding this this particular medication combination that led to sort of a cascade of outcomes. I could also anticipate perhaps a proactive model looking at In this part of the country, we have ED alerts. I don't know how localized that is, but it's sort of an emergency utilization flagging system. So I could see similarly a high utilization model benefiting from early psychiatric integration. And as you mentioned, some of these outcomes, looking at hospital length of stay, perhaps use of restraints. You could look at antipsychotics on the discharge medication list. You could really identify a number of assaults against staff. You can look at things many different ways to be able to measure that value. Ideally, there's a field in the medical record that measures it and allows you to study it pretty easily. But yes, lots of potential to show how early psychiatric integration into these different environments can really improve that care.
Excellent. Well, for purposes of time, we're going to call it here. I appreciate our audience asking all these questions. Sorry we couldn't get to every question there, but also appreciate both of our panelists, Dr. Dietrich and Dr. Bowie, for their excellent case presentation, discussion, and Q&A session. And I appreciate you representing your SIG in this regard. It's a great way of spreading the word of the good things your SIGs are doing. Thank you all to the audience. And just a reminder, the video recording of this case conference will be posted to the ACLP website and most of the social media platforms that ACLP or CL is involved with, such as the CL Pin Facebook page, Twitter, now X, and all those other categories as well. So thank you all for coming, and we'll see you again next time.